about 12 years experience working in the mental health field, both inpatient and outpatient. I am also one of the trauma-informed therapists here at Northeast. Also, I am able to do some training on that. I know a bunch of you guys have participated in those trainings with me before, along with my co-partner, Jeremy. This time we are doing one on suicide prevention. Like I had asked earlier, I made sure everybody here was from Northeast, so we all know and should be familiar with all the protocols here with suicide, but we all work, you know, in different areas and departments. Like I said, I'm in the outpatient adult department. We have probably some of the scan therapists on here. I saw ACT, I saw FACT, I saw clerical, I saw some of the PAs, all different departments on here. So some of us need to know more so about it than others, but it's very important for all of us to have at least a gist of it. Because you never know what we're going to come across, you know, in the hallways, out in the waiting room, in our offices, in the parking lot, on the street. So not only is it good to know this stuff, you know, in our work environment, but it's good to know it also in our personal life. Okay, so Northeast Counseling Suicide Care Management Plan is committed to achieving a zero rate of suicide within the organization and community. In doing so, Northeast Counseling subscribes multiple layers of a policy and procedure through a suicide care management team to identify, assess, engage, and provide appropriate treatment and intervention for individuals identified at risk, both prior and past. In response to Northeast Counseling Services' ongoing efforts to work towards the Zero Suicide Initiative, this suicide care management plan has been implemented for daily use across all levels of the organization. So what is suicide? Suicide is the act of intentionally taking one's own life. It's death caused by a self-inflicted harmful act with an explicit intent to die as a result of that behavior. So there's different suicide terms. The first one is suicide ideation. It's thinking about, considering, or planning to take one's own life. A suicide attempt, a potential harmful act that is self-inflicted and made with the intent to die, but does not result in death. Self-harm, behavior that causes self-harm but is not done with the intent to end one's life. And then assisted suicide, the act of helping another person end their life, often at their request. This is distinct from suicide, though the two are related. So a lot of people don't know the difference between suicide and suicide attempts and ideation and self-harm. So there is a difference. So self-harm or self-mutilation is the act of deliberately inflicting pain and damage to one's own body. Mallory actually does a wonderful training on self-harm, so you all should sign up for the next one she does, or see if you can find it on the network. Individuals who self-injury may feel that doing so helps release some symptoms, pressure, pent-up feelings of anxiety, anger, guilt, sadness. And there are some examples include cutting, burning, scratching, and consuming toxic amounts of alcohol, drugs, chemicals, or deliberately participating on unsafe behaviors such as sex. Some facts on suicide in the United States. They probably could be updated, but here's ones from a few years ago. Suicide is the 10th leading cause of death in the country. It's the second leading cause of death for ages between 10 to 24. I remember at 10 years old, I never actually thought about suicide, but at 10 years old, I was playing with Barbie dolls. Now 10-year-olds are going on TikTok and dressing in little outfits and having boyfriends and having sex. And I think back and I'm like, I was innocent and playing with Barbies. So at 10 years old, recently, I think a 10-year-old boy committed suicide because he was going through, bullying and stuff, and he reached out to some online thing, Chat GPT, I think it's called, and had asked, how to do it, and it actually told him how to do it, and he actually was successful. So definitely that's something that's new in this world, is this program, and they need to definitely tweak that program, I guess. Between 1999 and 2019, suicide increased by 33%. So over 10 years, or no, is that 20? Yeah, 20 years, it increased by 33%. That's a lot. And then in 2019, 47,000 Americans died by suicide. 18,000 of American deaths were in Pennsylvania alone, translating to 1 death by suicide every 4 hours in Pennsylvania. There were over 1.3 million attempted deaths by suicide each year. 10 million adults think about suicide. Women are more likely to attempt than males, but males are more likely to die. White males ages between 45 and 64 are at the highest risk, and young children or adolescents 15 to 24 had a rate of approximate, I can't see it, 15% death by suicide. So common myths about suicide. So talking about suicide increases the risk that someone will act on the thoughts. Reading this had me question. I remember when I was working at the hospital, I worked at multiple units. I worked on the children's unit, the adolescent unit, adult unit. And anytime somebody was going through a tough time, I would question them, It was something that was also on our progress notes. So obviously, if it's on the progress notes, we should be questioning, have you had any suicidal thoughts? And I would ask that because it was part of our everyday notes. And when I went on the adolescent unit, I had asked, and one of the adolescents had said yes. And it was my, policy then, it was to go talk to one of the nurses and let them know. As the position that I was in, I wasn't allowed to do anything besides, inform someone superior to me. So that's what I did. I went and told the nurse, and the nurse's response was, can anybody guess what the nurse's response was? Nobody wants to take a stab at it?
Maybe doing it for attention or disregarding the whole statement.
They said, do not ask any of my adolescents if they are suicidal, because they will say yes, and they will do it for attention. So even though it was on my treatment plan or on my progress note, was the client suicidal? She's telling me I am not allowed to ask because that will make them suicidal. So that's just like a common myth. If they're truly suicidal, they're more than likely not going to tell you. They're going to hide it from their support team, their loved ones. Next myth is suicide occurs out of the blue. Usually it's something that they are thinking about for a while. They have a plan. They try to figure things out, get whatever's done on their bucket list. Next one, if someone looks like they have their life together, he or she is not at risk at dying by suicide. Those are actually the individuals that are more at risk. So making sure that you check on your friends, your loved ones, especially the ones that seem like they have it together. I always tell my clients, especially the ones who struggle with social anxiety, you see somebody in the waiting room and you like their sweater, you tell them you like their sweater. You see somebody in the waiting room crying, doesn't hurt to ask, hey, you okay? Because you telling that person, hey, I like your sweater, or hey, you okay, shows that you're interested, that you care, and that might stop them from doing something like suicide or self-harm. So that's one goal I have for most of my clients is, talk to strangers in public, have small conversations. You know somebody crying, say something. Actually, there was somebody crying out in the waiting room, maybe about 2, 3 weeks ago, and she didn't want to be bothered, but one of my clients asked her, "Hey, you okay?" And she was like, "No, but thank you for asking." So any little bit counts. So it's very important to check on strangers, loved ones, support, staff, your children. It's very important. Keeping your eyes open, especially for the ones that seem like they have their life together. Suicides increase around the holidays and the winter season. The winter season is hard, and this is one thing a lot of my clients struggle with. It gets dark early, it gets cold. So finding different things that they could do to cope with the weather and the dark hours. So being aware of that. Also, the holidays could be tough because, a lot of people associate holidays with loved ones. And if loved ones have passed or they're alone or friends have passed, friends, family, animals, they associate that with the holidays. So just being more self-aware of your loved ones and your clients around the holidays in the winter season, preparing for that. Someone struggles with the loss of somebody and the holidays are coming up, which is also usually the winter season. It's something you probably should be talking about, preparing them. If someone really wants to die by suicide, he or she will find a way. I feel like, yeah, that could happen, but also a lot of times they're looking for that help. They're looking for an answer. So like I said, just listening, talking, being more self-aware. And then attempting suicide is for attention. It's not for attention. It's really what they think is their only way out, unfortunately. They're in such that state that that's the only solution at that time. Uh-oh. I think my screen froze. Okay, all right. So warning signs and risk. Okay, so there's some verbal cues. There's some verbal things that your clients, your friends, your loved ones could be saying to you. There's so many out there. So just being more self-aware of anything that your clients are saying that are out of ordinary than what they typically say. And that's your cue right there. So some examples include, no one would miss me if I was gone. They don't care that much about me anyways. It would be easier for everyone if I was gone. I'm a burden. I can't live like this. I don't care. I don't know. Like I said, just if someone is acting or saying or doing stuff out of the ordinary, definitely it's something to look into more. So some behavioral cues, talking or joking about suicide, making it look like since they're talking about and joking about it, oh yeah, I'm not going to do it. Yeah, but really they're doing that just to distract you. Giving away stuff, personal stuff, putting end of life affairs in order, making a will, paying off debt, making a plan such as stockpiling pills, researching online, buying a weapon, having a preoccupation with death and violence, high-risk behaviors such as increased substance abuse, doing just risky behaviors, self-harm, being clumsy, I guess, in a way. So having several accidents resulting in injury. So like not caring, like, oh, I shouldn't go here because I'm going to get hurt. But guess what? They go anyways. Previous suicidal thoughts or attempts, that's a huge one, being very aware of that. And withdrawing from their family and friends. So there's definitely a bunch of risk factors, warning signs, family history, past trauma, current trauma, past abuse, current abuse, veterans, current, individuals in that category, correctional staff, incarcerated individuals, certain individuals of a cultural race, the LGBTQ, and I feel like there's a few more other letters now, community, they have a history of substance abuse, if they're impulsive, if they have a poor medical diagnosis, chronic disease or disability, lack of services, you know, if there's waiting lists or they can't get into something, or there's not being offered to them. History of psychiatric disorders, especially depression and high levels of anxiety, have to really keep an eye on those individuals who are extremely depressed and or have higher levels of anxiety. If your clients, your loved ones are telling you, you know, they're severely depressed or severely anxious, those are the ones that you need to, you know, really keep an eye on. You should be keeping an eye on anybody who's anxious or depressed, but those are the ones that have the higher chance, higher risk of attempting suicide. High levels of stress, lack of sleep, homeless, lack of social supports. Unfortunately, in this community mental health setting, a lot of our clients have a lack of social supports. And with that being said, it's because their social supports aren't always the positive ones. So especially our clients, we should be keeping an eye on. Loss of identity, you know, struggling with their gender, retirement, job loss, hopelessness, sudden change or improvement in mood, and if they have access to weapons. Few things I want to go over, because we all have, you know, the actual staff here that work with clients directly. I'm sure we have very similar, you know, questions in our notes to go over, you know, such topic. So I know in our clinical assessment and in our treatment plan, ask, you know, do they have access to a weapon? And also discuss, you know, treatment plan, clinical assessment, progress notes, all questions about the history of suicide and current thoughts. And this is all stuff that should be asked every single time. You know, you should be asking it in the clinical assessment. It's on the assessment itself. You should be asking it in the treatment plan, because they might report it to, you know, the intake worker and not report it to you, or vice versa, and then you're missing something. So it's very important to dot your I's and cross your T's. And also, like I said in our notes, it asks, you know, if they have, you know, thoughts, intention, or a plan, or anything other. So definitely, you know, going over that. We also have different assessments that we can do with our clients. There was one that I'm going to go over in a little bit. We actually were given recently a paper copy in our mailboxes. So that's a good one that can be utilized, and I'll go over that one in detail. And then there's I came across, there's two actually on GreenSpace. For those who don't know, GreenSpace is a program that therapists can use to assess symptoms, anything from depression to anxiety to social problems to suicide. So that one is on there as well. So definitely making sure you're asking your clients. I'm sure it's also in the physician's notes as well. You know, are you suicidal? It should be something that's being asked. The next thing is, like I said, the access to weapons. That one's in most of all the notes as well. It's not in our progress notes, I don't think, but it's in the treatment plan and our clinical assessments. So it's important to ask that, especially if, you know, they have a history of self-harm or reckless behavior even, or suicide. And being so aware of those individuals who do have access to weapons, and where are they being stored? Do they have, you know, a license to carry? Are they on probation? Are they on, you know, are they in a drug and alcohol program? All this is good information you should know already, but making sure you put it all together to see if really should they be having a weapon? And is it a concern at this time? I actually, years ago had a client who was just going through a rough time. She has a significant history, of trauma, and she has her, license to carry. And, I knew that. Um, and I've been seeing her for a very long time. But if I didn't know that and remember that, and when she was suicidal, she wasn't reminding me that she had that gun. So it was important that I remember, and I said to her, I said, you need to hand that gun in, right? And she said, yeah. And that's what we did. We came up with a plan. She handed that gun into a family member. When she was stable again, she was allowed to have that gun back. And that was our plan. And that was the plan that the whole treatment plan agreed upon. And that was, like I said, a few years ago. And to this day, she is doing a lot better. So there's no concerns at this time. But do I have that in the back of my mind of what clients have a gun? Or any type of weapon? Absolutely. I could probably look through my list right now of 70 people and tell you, at least as long as they reported to me, which ones have a gun and which ones don't. So that's very, very important. So what happens if you see or hear these warning signs, or if your clients are reporting to you that they're suicidal? So as a therapist, you should be consulting. You should be consulting with your supervisor. You should be consulting with your psychiatrist. If the psychiatrist is not here, you should be calling the on-call psychiatrist. And also, I think it's very important for us to be informing the PA as well, especially if they're seeing the PA more often. And I feel like these rules go across departments. I'm sure, the ACT team and the FACT team have to do the same thing. A therapist is going to the house and someone reports that they're suicidal. I'm sure they're telling, their supervisor and the psychiatrist. So definitely consulting with them, having a treatment plan or a treatment plan. Yeah, I guess a treatment plan put in place. And usually it leads to them going to see crisis, and usually they're more than willing to go see crisis. But making sure they're not left alone in your office. They can easily, do something they shouldn't do. They can leave when you leave. The good thing is, and I don't know if other programs, have the accessibility to it, but we have this new program. It's called Teams, where we can chat. We're on our computers already when the clients are in here, so we can just send a message to chat. Hey, can you come over for a minute? And then we can discuss what's going on with him, with the client. I found that clients are, more willing to participate and cooperate if they're involved with everything and you're not being sneaky. So letting them know, if this happens, you may or may not have to see crisis, or you may, have somebody come visit you at your house, or you may have an emergency worker call you. So definitely, depending on the severity and depending on their history and whatever the game plan is whatever the safest option is for them. Like I said, is it seeing you more frequently? Is it getting in and getting their medication changed? Is it going to see crisis and being evaluated? Is it having them stay with somebody? Is it having emergency services call them until, they settle down? It all depends on the severity and actually the situation itself. So just during that, making sure you remain supportive and calm, remove any immediate risk or access to lethal measures, and stay with the individual until everything is completed, or making sure somebody is with them and making sure they don't leave. I had an incident a few months ago where a client had told me that he wanted to go to the hospital, and there was actually no grounds, because at that given moment, he wasn't saying he was a harm to himself or others. And we explained to them, you can't just go because you want to. So, consulting back and forth on what we can do with him, blah, blah, blah. With that being said, in the meantime, I turned my head for a second to do something on the computer. And what does he do? He pulls out a knife. And he goes, I'm gonna cut myself in, I'm gonna kill myself in here, Caitlin. That's what he said. I'm gonna kill myself in here. And he tried cutting his wrist in front of me. What would you have done in that situation? Anybody want to give an example of what you have done in that situation?
If it was in my session, I would honestly try and grab his arm safely and yell for a coworker to go get someone.
Okay, yeah. So that's very, very similar to what I did. I walked over to him. I grabbed the knife out of his hand. I put it behind my back and if you know how our offices are, you can pretty much hear through them. Mike can probably right now hear my loud mouth and hear me through the camera. So he probably doesn't even need his volume on. But that's what I did. I just yelled for him. He came right over. He took care of it for me. And then the police were called for other circumstances. But sometimes things like that happen, so you have to just, remain calm, be aware, that even though they're not supposed to, be bringing these things in here, sometimes they do. I can't tell you how many times a client will be like, oh crap, I left this in my pocket, and then they have to go run outside to put it away, whether it's a gun or a knife or a taser. Some people disregard that sign on the door, or they really don't care, or they don't see it, so you always have to be self-aware and never let them alone, especially if they are suicidal. We always have staff walking around and just grabbing somebody, hey, can you sit with them for a second? Or like I said, utilizing that chat, hey, can you come over here for a second? Leaving your door open. So suicide screening does not increase the risk of suicide. So like I said earlier, asking him does not increase it. And it does not predict who will die by suicide. What it does do is it gathers information, history or present, identifies who may be at risk, and identifies who may benefit from an intervention or to complete an assessment form. So here's the assessment form that I was talking about earlier. So it's our suicide risk screening tool. Like I said, we were given, therapists, we were given a copy in our mailbox. So definitely, taking a look over that and using that on individuals. What I would do is if a client is suicidal, you consult. But maybe if you're not sure, or they're not sure, or you're getting mixed messages, this would be a good screening to utilize. So if the individual answers no to all questions, you're unsure if they are, and you do the screening and everything answers no, I feel like I would still consult with your supervisor, and he can determine whether or not, consultation has to happen with the psychiatrist. But if they answer yes to any of them, obviously you should be consulting with the supervisor and the psychiatrist. So this pretty much just says what I say, what I just said. Depending on how, severe the case is, determines what type of aftercare will happen. Like I said earlier, usually they get referred to crisis, and crisis usually does an assessment. So make sure when you're doing your screening, you're asking how often do you have the suicidal thoughts? How often do these thoughts typically last? How in control do you feel about them? And are there things that you can think about or do to deter these thoughts? And then what are the reasons you are feeling or going through that are leading to these? So trying to understand why they are feeling this way. Sometimes they don't understand. So definitely asking open-ended questions can actually help with that. I have clients who, well, I don't know why I'm depressed. And then I ask them open-ended questions, and then they're like, yeah, maybe that is why I'm depressed. I don't know why I'm anxious. Well, did you just go to an extremely busy concert? Well, yeah. And you have a hard time socializing, right? Well, yeah. Well, that could be why your anxiety is a little higher. So definitely asking open-ended questions to explore their thoughts and their feelings. So a positive screening leads to an assessment. So like I said, utilizing that brief suicide safety assessment, there's two versions. There's an adult one and a child one. Making sure you're, motivating them to respond, appropriate, well, not appropriately, but like in detail, and thanking them for being honest with you. And then also it should be completely alone. Therefore, you shouldn't be helping them with the assessment. Unless they are unable to read or write, then you can help them, but you shouldn't be doing anything that would deter their answer. So based on, like I said, multiple times, and I'm going to tell you 100 times more, based upon the assessment, consulting with your supervisors and psychiatrists, updating the PA, developing a plan, reducing any risk. So, securing weapons, that's a big thing. You have access to weapons, making sure they secure them. You live alone, maybe you should go stay with your friend. There's a bunch of things that could be done to reduce the risk. Treat and reduce the symptoms. So is that a medication change? Is that more frequent appointments? Is that using your coping skills? Connecting with support. So talking to family, friends, us. Identify reasons to live and protective factors. That's a big thing, making sure they have reasons to live. Well, if they're planning for the future, then they're more than likely not going to commit suicide. Gaining commitment to contacting someone if thoughts become stronger. So making sure they're agreeing to that, contracting for safety, being aware and sensitive with them, and then considering incorporating faith. That's a big thing. That's something that's always discussed in my sessions because it is on the treatment plan. Are you religious or spiritual? And so if I have someone, who is, we talk about that. Also, if they're not, then I question, maybe you should consider going to church or practicing a faith. And some of them are like, yeah, and other ones are like, no, but it's just an option for them. So crisis and safety planning. A safety plan is a written list of coping skills, aka personal medicine, that we call it here, and sources of support developed by the treatment plan, the treatment team, with the individuals who are at high risk for suicide. Really, it should be done with all individuals. We have a crisis and safety plan on our treatment plan, and that includes, their support, their triggers, their warning signs, their coping skills. So this is actually, we have this for all our clients. It reduces access to lethal means. It teaches brief problem solving and coping skills, and enhances support and identifies emergency contacts. Using motivational enhancement to increase likelihood of engagement in further treatment. So what is a safety plan, aka coping skills, aka personal medicine? So it's a list of simple external, so things that happen on the outside, and internal, things that happen on the inside, activities that a person can choose to use when they're feeling triggered or overwhelmed. There is no universal safety plan, which means we all have different coping skills that we use. We may have similar ones, but we all have different ones that, if we have a top 5, you know what I mean? My first one might be deep breathing, whereas your 5th one might be deep breathing. So we all have different coping skills. So like I said, internal safety plans are plans that focus on what a person can do mentally to remain calm, such as, positive thinking, deep breathing, progressive muscle relaxation, and so forth. External safety plans are plans that focus on what a person can physically do, going for a walk, listening to music, talking to a friend, and so forth. Does anybody want to share some of their coping skills?
I like using picky pads.
Very nice. Okay. So triggers. What are triggers? something that sets off a memory tape or flashback, something that makes the individual experience symptoms of anxiety, depression, anger, PTSD, anything that makes you feel not like yourself. But triggers are very personal, which means one thing might trigger me, but may not trigger another person. Sounds, something they see, something they taste, something they feel. Like I said, different things trigger different people. A person's triggers can be activated through one or more of the five senses: sight, sound, touch, smell, and taste. And some of the triggers can be from current or past trauma and abuse. So in the trauma trainings, we talked about ACEs, adverse childhood experiences. These are things that happen during your childhood, abuse, trauma, that could affect you as an adulthood. The more ACEs you have, the more likely that you will have symptoms of mental health, more triggers and stuff like that. So anything could be a trigger for somebody who's suicidal. So they might have had a bad childhood, and that could trigger them, as an adult, thinking about that, seeing somebody they can relate to. All those are triggers for them. Being reminded of something, or current stuff. If they're going through current abuse or current loss of a loved one, that could be something that's triggering to them, which can lead to self-harm or suicide. So doing our part, both client and as a mental health professional, preventing, so using our coping skills, asking questions, making sure we're asking every session, avoiding the triggers. If they know their father who abused them is something that triggers them, well, maybe they should either A, avoid them and stay away from them, or work with therapists and find a way so they could be comfortable around their father. Responding, so outreaching, us reaching out to clients. If we know that something's off, contacting them. If they call and they're like, hey, you busy? And you're like, yeah, I'm having a really busy day. And they're like, oh, and then just wait, this is not normal for them. Maybe I should make time for them. Because sometimes they just want to tell you that they won the lottery or something, but sometimes it's something serious. So just being more self-aware of that, making time for our clients. You see them in the waiting room, saying hi to them. They might actually end up not have the confidence to call you and say, hey, I need a session. But you see them out in the waiting room, you're like, hey, and they're like, oh, hey, got some time? So having some outreach for them, making sure they're outreaching to you. So providing them with the resources, the helpline phone number, your direct line, our emergency services, the crisis, any resource that we have, so they have it available for them. And then putting a plan in place, whether it's sending them over crisis, having the emergency service call you, seeing you twice a week, going to see the doctor, whatever that plan is put in place. So how could you do your part? So right now, this is how you're doing your part, is you're becoming more informed about suicide. Asking questions. So asking your client, asking your client open-ended questions. If something seems off, asking them questions. If you're unsure about something, asking a peer, asking a professional peer. Having a checklist in place, making sure you're going over certain things every session. And then making sure the biggest thing is consulting with your treatment team. So transition of care. So Northeast Counseling is sensitive to an individual's needs and emotions during an episode of suicidal risk. With this in mind, in the event that screening and assessment does result in the need for a referral to an alternative level of care, Northeast Counseling staff will provide a handoff. So like I said, usually, within outpatient programs, if, they need a higher level of care, crisis typically takes care of that. And then they typically, send them over to one of the hospitals, and then one of the hospitals will refer them if a need arises to a psych hospital. Staff will maintain direct contact. So, crisis will inform us of the update, and then we will be made aware if they're admitted or not. And then making sure we're seeing them, important thing is making sure we're seeing them within 48 hours, if not the same day as discharge, from the hospital, whether they ended up going to the regular hospital or the psych hospital, seen by crisis, called crisis over the weekend, they need to be seen within 48 hours, particularly within that same day. And making sure our clients are aware of that. That is in our consent to treatment. And if they are unable to agree to that, then they could be closed out services. But I never had an issue with anybody coming in. Hey, you were in the hospital, you need to come in today. Okay. The only problems I've run into is if they're in a hospital in Philly or Allentown and they're farther away, that makes it a little difficult, especially if they're discharged later in the day. But our psychiatrists and our PA, they work very well with us, and if we can't see them, they see them, and vice versa. And then making sure we're seeing them more frequently, if they were in the hospital or seen by crisis. So offering twice a week, or if they were only coming, bi-weekly, offering weekly sessions. Okay. So some things we need to consider as mental health professionals. Secondary traumatic stress. It's the behavior and emotions that result from knowledge about traumatizing events experienced by another, and the stress resulting from helping a traumatized or suffering person. So hearing someone or, going through with someone who is struggling with severe depression, anxiety, and being suicidal can be hard. So just being aware of that and getting the help that you need, talking to another staff member, being aware of burnout, using your coping skills, asking for help. So the next one is vicarious trauma. Experiences emotional, psychological distress after hearing about the traumatic experience of others, or actually witnessing it. Like I said, after witnessing that client attempting to cut themselves, I was shaken up for a few days, but my fight mode was in, and I was able to take care of it. I didn't freeze, and that, as a mental health professional, that's important, just to be aware of what could or could not happen and be prepared, because that may or may not have saved his life. And having some compassion fatigue, the natural, predictable, treatable, and preventable unwanted consequence of working with people who are suffering. Sometimes we have clients that things don't change, and it could be very, very tiring. So is that, does that come to, talking to them about it, or talking to your supervisor and seeing if they would be a better fit for another therapist or for another service. And then burnout, a collection of symptoms associated with emotional exhaustion and generally attributed to increased workload and stress, described by a process that includes gradual exposure to job strain and idealism and lack of achievement. So being aware of that when you're getting to that point, taking a step back, asking for help, talking to your supervisor, taking some time off. So in summary, making sure you're screening, assessing, consulting, planning, and supporting. Have some hope with the clients, and it's treatable, and there is help and resources available 24/7. That's that. Anybody have any questions?
Nope.
Thanks, Courtney. David?
I'm just going back at the chat and seeing if I missed anything, if anybody had any questions. Someone said they like to use the SAFE-T to assess for suicidal, homicidal concerns. Very nice. Someone said they like painting and going for a walk, class coping skills. Someone likes to make cards for holidays and special occasions, sitting in the park and listening to all the sounds, art. Okay. All righty, I think that's it then. All right, everybody have a nice Thursday.
Thank you.
You're welcome.